I'd like to welcome everyone to the webinar. Today's is called Themes Emerging from the 2018 National Residence Survey, a detailed look at the data from the 2018 National Residence Survey in the context of the PGME environment, and a discussion of potential solutions to these issues. My name is Zay Schwetz, and I'm currently a PGY3 in emergency medicine at the University of Saskatchewan. I'm also the president of Resident Doctors of Saskatchewan and the wellness co-chair for Resident Doctors of Canada. It is my great pleasure to introduce our panelist for today's discussion, Dr. Michael Arget. Dr. Arget is the 2018-2019 president of Resident Doctors of Canada and a co-chair of RDoC's National Residence Survey team. He is currently a PGY3 in internal medicine here with me at the University of Saskatchewan. Before we start, just a bit of quick housekeeping. I'll be asking Dr. Arget a number of questions throughout the presentation. There is a lot of time for other people to have questions that we answer during the session. So these questions can be submitted via the chat window that's built in just on the right side of your screen. I'll do my best to relay them as we move through the information. The webinar is also being recorded. So for all of your colleagues who are too busy to join us right now, you can let them know that we'll be broadcasting this on RDoC's YouTube channel at a later time. So without any other ado, Mike, why don't we get started?
Thanks, Zane. Hi, everyone. It's a pleasure to be here on behalf of the National Survey Team for Resident Doctors of Canada. And I'll start by providing a brief introduction to RDoC and then also to the survey. So Resident Doctors of Canada represents over 10,000 resident doctors across Canada. It was established in 1972, and we are a not-for-profit organization providing a unified national voice for our membership. So RDoC collaborates with other national health organizations to foster excellence in training, wellness, and patient care. The results of Resident Doctors of Canada's 2018 National Survey provide valuable empirical data on a number of issues faced by today's resident doctors. The survey was distributed in April 2018 to members in British Columbia, Alberta, Saskatchewan, Manitoba, Ontario, the Maritime Provinces, and Newfoundland and Labrador. Members were asked to provide their views on a number of issues in medical education and residency training, resident wellness and career intentions, and practice management. Talking about these issues is an important step to improving our medical education training system. In regards to the actual survey, the overall national response rate was 8.3%. Survey results were weighted to reflect the gender, training faculty of medicine, and broad training specialty group to allow for reflection of general characteristics of the RDoC membership. Today, I'm going to cover 3 specific topics, including competency-based medical education, resident wellness, and career intentions in national locum licensure. Let's begin with a look at CBME.
This is exciting. Thank you, Mike. So what do our respondents have to say about CBME?
Thanks, Say. So as we all know, CBME is being introduced to all postgraduate medical training programs in a staggered fashion through the Royal College's Competency by Design initiative, as well as the College of Family Physicians CCC initiative. Some residency programs are already partaking in CBME, while other programs will introduce the model in years to come. RDoC's training committee wanted to get the resident perspective on how the transition to CBME is going and where the benefits and drawbacks are. Here's some of the data we collected in the 2018 survey. So as you can see on the slide on the screen, slightly over 30% of residents reported that CBME had been rolled out in their programs, 17% of which were formally participating in this new training model. For residents who can confirm the rollout in their program, irrespective of their own participation, 64.4% stated being adequately informed about CBME. When the same group was asked if they felt that their preceptors were adequately informed about CBME, only 36.5% answered in the affirmative, and 20.1% did not know. When asked if they felt the infrastructure in their program to support the transition to CBME was adequate, 46% agreed and 25.9% said they did not know. Residents who had seen a CBME rollout in their program generally agreed, 84.6%, that CBME was advocated for and supported within their program. Also that their program welcomed feedback from residents on CBME, reporting 69.9%. When all respondents were asked about the greatest benefit of CBME, the most frequent answer was don't know at 22.5%. While low, this figure may reflect the relatively low level of direct experience of CBME by residents due to the limited rollout at the time of the survey. The two most frequent responses about the greatest benefits of CBME were that it improves the quality of feedback, which was 18.6% of respondents, and then that it formalizes and standardizes learning objectives at 17%. In contrast, evaluation fatigue at 31.9% and time burden, 24.2%, were identified as the greatest challenges of CBME for residents. When asked about the greatest challenges of CBME for preceptors, the above two challenges also had the top two frequencies, but in reverse order, with time burden at 37.5% and evaluation fatigue at 33.9%.
Mike, this is really fascinating. It'll be interesting to see how these answers change as CBME continues to roll out. How is RDoC as an organization involved in these processes?
Thanks, Say. RDoC continues to play a central role in CBME development in Canada through national advocacy work on behalf of our members and ongoing formal communication with the colleges. We help to ensure that the learner's point of view is taken into consideration in any proposed changes. RDoC has also provided feedback to the Royal College on the Series 1, Series 2, and Series 3 CanMed drafts.
So what kind of solutions does RDoC advocate for when it comes to CBME?
As we all know, the transition to CBME affects the entire Canadian medical education community. To properly implement a CBME approach, colleges, faculties, programs, hospitals, and other stakeholders need to work together. Here's what RDoC advocates for. So number one, planning a smooth transition, including creating a robust CBME strategy, facilitating the successful implementation, seamless incorporation, and buy-in of new assessment methods and teaching approaches. Also, creating standardized CBME language that includes shared definitions of entrustable professional activities, what we all know as EPAs, milestones, and competencies. And finally, collaborate, coordinate, and exchange information in order to develop consistent specialty-specific EPAs. In addition, we're also looking to innovate in curriculum design. So this includes clearly defining training requirements and service expectations and clearly presenting them to faculty and residents. We're also looking to ensure residents obtain their competencies primarily through direct clinical exposure. Also, relating milestones EPAs to residents' future practice and development as competent integrated physicians. Also of note is ensuring that residents have a sufficient variety and depth of clinical exposure, as well as developing new scheduling and delivery approaches that ensure quality for both traditional and CBME trained cohorts. Finally, engaging in continuous quality improvement efforts to assess, improve, and adjust approaches over time. Another piece or prong that RDoC is working on in the area of CBME includes re-engineering assessment and promotion activities. So this includes aligning assessment and promotion with a competency-based approach and making it transparent. Also using multiple assessment tools that enlist various assessors, adapt to varied learning environments, and promote formative feedback and self-reflection. Also tracking residents' progress through a learning portfolio, identifying any residents who require additional resources as early as possible, designing examination content to reflect a training stage of training and competency, and expanding their capacity so as to not delay training progression. Finally, making promotion the responsibility of the program, not the certifying or licensing body, and decoupling assessment from residency matching or hiring processes. And finally, do not use data on patient outcomes to assess competency. The final prong that RDoC is working with on CBME looks at allocating new resources to supporting residents and faculty. So this includes ensuring adequate physical, human, financial, and technological support, developing cost-effective strategies that identify system inefficiencies and support continuous quality improvement to ensure that resources are diverted to CBME transition and do not compromise patient care programs or postgraduate medical education offices. And finally, most importantly, and one of the biggest issues is respecting time and demands for residents and faculty who will be adapting to new assessment and teaching methods, as well as faculties showing support to training by establishing CBME champions.
Thank you, Mike. This is really exciting work that RDoC is doing. Where can people go to find out more about these initiatives for RDoC's work on CBME?
Thanks, Say. So I encourage everyone to look at the slides provided and to go to the link looking at the areas of focus for CBME on our website. Here you can find our position paper and a number of other resources. There's also a link to a feedback survey, which I encourage all residents experiencing the implementation of CBME to complete so we can feed that back to the colleges.
That's excellent. So I'm going to take this moment right now to remind anyone tuning in that they can send questions throughout the entire webinar that we're hosting right now. So just go ahead into the chat box and type away. We're happy to field questions as we go along. Currently, I don't have anything waiting, Mike, so maybe we can keep moving along. Let's go to a topic that is near and dear to my heart, which is resident wellness. What did respondents have to say about wellness on our survey?
So resident wellness is one of the top priorities for RDoC and one of the areas that we do a lot of work in, both Say and myself. It's fused throughout all aspects of our strategic plan, and we want to ensure our members work in positive, safe, and diverse learning environments and work environments. The 2018 National Survey asked members about a number of issues related to resident wellness. As we don't have time to cover them all today, I'm going to focus on two major areas, including intimidation, harassment, and support resources in mental health. So let's start with the intimidation and harassment data. So our survey showed that intimidation and harassment is prevalent. More than 3/4 of residents, 78%, experienced at least one form of harassment or intimidation during the year preceding the survey. The most common form of harassment or intimidation experienced was verbal comments, reported by 95% of residents. Patients, 77%, as well as allied health professionals at 55% and staff physicians at 52% were the most common sources of harassment or intimidation. Other types identified included work as punishment, 21%, privileges or opportunities taken away, 17%, sexual harassment at 11%, or inappropriate or unwanted physical contact at 11%. Also noted was recrimination for reporting at 8%, or other, which was 11% of respondents. Other reported sources included the program director at 8%, fellow residents either in another program or in their own, 36% or 19% respectively. Experiences of harassment or intimidation during the reference period were more frequent for men at 86% over women at 71%. Reported harassment or intimidation also varied by broad medical specialty, with the lowest rate seen in our family medicine trainees at 70% and the highest rate seen in the surgical resident group at 86%. The basis of the harassment or intimidation reported by residents was highly varied. While gender was frequently cited at 38%, other bases of harassment or intimidation described by respondents made up the majority, 53% of the answers. These excluded categories such as ethnicity, culture, and language, and often focused on professional characteristics of the residents, such as rank or specialty, or characteristics of the patient, including diagnosis, sequelae, or disagreement about treatment course, for instance. When asked if their program, medical school, or university has a policy to address intimidation and harassment, 1/5 of respondents did not know the answer. Of those who knew about such policies and who had experienced a form of harassment, 10% had used that institution's resources to these events. When the latter were asked if they felt that resources to address intimidation and harassment were adequate in their program, medical school or university, the majority, 61%, said no. We know that this is an ongoing issue. In our 2012 survey, it was noted that beyond their program director, many residents remain unsure as to who or what they can turn to as a resource for dealing with inappropriate workplace behavior. Also, in the 2013 survey, when asked what steps they had taken to address the inappropriate behavior they had witnessed or experienced, more than a third of respondents, 32%, indicated that no steps had been taken. Importantly, for those who said they did not take any steps to address the inappropriate behavior, the most commonly cited reasons were that this would not change or remedy the situation, which had 34%, and also fear of reprisal, which was 21%.
Mike, these numbers are really intense. What solutions does RDoC advocate for when it comes to dealing with intimidation and harassment?
RDoC maintains that intimidation and harassment prevention is necessary to improving the work and learning environment for residents. Residency programs should focus on creating and maintaining a positive work environment for staff physicians, resident doctors, medical students, and all members of the healthcare team. In 2016, RDoC called on the postgraduate medical education deans to take the following steps. Number one, that faculties of medicine in Canada, including PGME offices and program directors, work with the national certification colleges, hospitals, and residents to update the 2004 Intimidation and Harassment Guideline, accreditation, and the issue of intimidation and harassment in postgraduate medical education. Number two, that faculties of medicine in Canada review and update as necessary their own workplace improvement policies and procedures on an annual basis, and ensure that this information is readily and universally accessible. And finally, number three, that these policies incorporate the following key components. Number one, promotion of a culture that values and promotes well-being throughout the continuum of medical training and adopts a zero tolerance approach to intimidation and harassment. Subpoint two, development of a free open forum for resident doctors to be able to safely report inappropriate behaviors when they occur. And finally, subpoint three, a time frame to examine events as they arise in order to prevent recurrence.
Thank you, Mike. Obviously, I think this is a really important topic. So where can people go to see and learn more?
Thanks, Say. So again, looking at slides that we have available to you. So RDoC's work on intimidation and harassment prevention can be found on the website, looking at the area of focus under intimidation and harassment prevention. And more importantly, I also want to draw everyone's attention to our focus website on optimizing positive work environment. It contains links to the policies regarding professional behavior, harassment, and related support resources that are provided by the various medical faculties in Canada. We hope that our members will find it useful if they find themselves in this situation in the future.
That's really quite excellent. Thank you, Mike. So another reminder that all of the audience can ask questions at any point during the presentation. Mike, I do have one question for you here, and I've got some information to add to it if you'd like. But the question is, when it came to sexual harassment, did we break down the data from where the source was coming from? So for example, when the resident was reporting sexual harassment, did it come from the patient? Was it coming from allied health professionals, staff physicians? And did we break this down?
No.
So my understanding is that we don't have it broken down as precisely as this question asks, but there is additional information in the report. Do you have anything you might want to add to that, Mike?
So thanks for the question. I think that we didn't break the information down to further classify. A lot of our concerns are related to intimidation and harassment and the numbers that we're reporting. We wanted to make sure that we were ensuring anonymity of the survey and not specifically identifying or isolating specific individuals and their experiences. If there is an interest, we do have access to the raw data and can do a deeper dive, but at this time, the overall push and analysis didn't look at that in particular. Sorry, and all I can say is there are additional details and the data tables in our national survey report, which can also be found from our website.
I think you bring up a really important point about anonymity. And if we look at our own results that show that up to 21% of residents don't report because of fear of reprisal, it's important when we collect this information to keep things as anonymous as possible to hopefully encourage residents to answer freely. So I don't have any other questions on this topic right now, which means maybe we can move on to talking about mental health.
Great, thanks, Say. So as we all know, residency is a particular dynamic and stressful time for many learners who must constantly balance educational, personal, and patient care responsibilities. The survey team knew it would be important to get a sense from RDoC members about the challenges they face in terms of their mental health and maintaining their own wellness. So when asked to evaluate if their work schedule leaves them enough time for their personal and/or family life, more residents disagreed than agreed with the question, this question statement. 47% would be categorized as negative for work-life balance versus 34.2 as positive for work-life balance. 71.6% of residents are in training programs where they work 60 or more hours per week, with close to 1 in 5, 18.6%, working 80 or more hours a week. The largest group of residents, 34%, reported working on average between 60 and 69 hours per week in their residency program. These numbers are consistent with our 2012, 2013, and 2015 RDoC survey results, whereby residents worked on average 62.3, 63.7, and 60.3 hours per week, respectively. Close to 1 in 5, 18.6 residents worked 80 or more hours per week, as noted. When not on call, the largest group of residents, 42.5%, slept 6 to less than 7 hours per night. Most residents, 80.3%, sleep 6 or more hours per night when not on call. These numbers are also consistent with our 2012, 2013, and 2015 RDoC survey results, where residents slept on average 6.9, 6.8, and 6.9 hours per week when not on call, respectively. And so I think that is per night on a weekly average, because if it was 6.9 hours per week, I think we would all have lots of trouble. Less than a third of residents, 28.2%, had no trouble at all falling or staying asleep or sleeping too much in the 2 weeks preceding the survey. The remainder, 71.8%, would screen positive for sleep disturbance. More than a third of residents, 33.8%, stated having sleep-related difficulties more than half the days or nearly every day in the past 2 weeks. Work-related fatigue has an impact on residents' work. 63.1% reported that it led to medical errors that did not reach the patient. Also, 20% reported that it did lead to medical errors that did reach their patients and patient care. When asked to evaluate their resiliency over the previous month using an abbreviated version of the Connor-Davidson Resiliency Scale, the majority of residents, 87.6%, reported that they were often or nearly always able to adapt when changes occurred. Most, 86.5%, were also often or nearly always able to bounce back after an illness, injury, or other hardship. Despite having this protective quality, the majority of residents, 51.9%, self-screened as positive for burnout. Residents are not likely to take sick days. In the 12 months preceding the survey, 2/3 of residents often, usually, or always went into work despite feeling ill or unhealthy. 15% screened as positive for depression. Reported depression rates were higher for laboratory medicine and surgical resident doctors than those training in family medicine or the medicine subspecialties. More than 1 in 7 residents have experienced thoughts of suicide in the last year, and 2.5% overall have seriously considered it. 18% of men reported thinking about suicide over the last year, with 22% of that group reporting having seriously considered it. By contrast, 14% of women reported thinking about suicide over the last year, with 9% of that group having seriously considered it. Further breaking down the numbers, 51% of laboratory medicine respondents who had reported thinking about suicide within the last year also reported seriously considering it. Rates were much lower for family medicine at 17%, medicine and subspecialties at 16%, and surgical at 11%. Causes of burnout may include difficult work schedules, stressful roles, intimidation and harassment, job insecurity, financial stress, and other causes. It is important to note that causes of burnout are not due to inherent higher risk in medical school applicants. Applicants have similar rates of depression as the general public, but depression becomes more prevalent as you advance on in medicine. Burnout affects clinical care, and it may affect physicians' abilities to go the extra mile for their patients. Resident doctors experience barriers to accessing mental health care. 59% identified lack of control over one's schedule as the most significant barrier, while 25% identified the existing culture in medicine that stigmatizes mental health as another significant barrier.
Mike, these numbers are really intense. What solutions has RDoC come up with to advocate for residents' mental health?
Thanks, Say. So this is a complex problem and has been one that we've been battling with in medical education for years now. And there is no one solution to this problem. As a result, RDoC is tackling this in a number of different ways. So first, and sort of as a fundamental basis, we're calling for adherence to resident contracts to ensure resident rights are protected when it comes to post-call days and call schedule limits. This helps ensure residents are working appropriate hours, reducing their risk of burnout. At this time, I want to give a shout out to all of our provincial house staff organizations, including Resident Doctors of Saskatchewan, which Say is the president of, who play a leading role in the negotiation and enforcement of the collective bargaining agreements, which outline these and other issues. Secondly, RDoC champions the promotion of a positive, safe, and diverse learning and working environment in medicine. RDoC recognizes that we work in a shared environment and that those working within it have a shared responsibility to each other. And with that, we have a shared responsibility to the populations we collectively serve. RDoC is hosting the first Positive Working Environment Summit in May. The objectives of this summit are to A, catalyze a national multidisciplinary conversation that assesses the current state of working environments in the Canadian healthcare system and identifies the various challenges to positive work environments. B, collectively identify potential areas of improvement in creating and maintaining a more positive working environment. C, establish a work plan to convene a larger multi-stakeholder summit in the spring of 2019. Also, using the summit to generate a series of recommendations and calls to action. And third, I suspect most people have heard of the Resident Doctors of Canada's resiliency curriculum. It's a practical skills-based and design module to help mitigate stress and optimize performance. It is instrumental in helping residents overcome both the anticipated and the unexpected adversities of medical training. The resiliency curriculum promotes the importance of mental resiliency in physicians by fostering supportive learning environments and advocating for a systematic approach to understanding and addressing stressors. Resiliency training prepares residents to transition to rewarding and sustainable careers, which yield benefits for patients and Canada's healthcare system as a whole. The curriculum also advocates for enhanced wellness resources with flexible hours for medical trainees, recognizing that it can be hard for residents to access care when they're expected to be at work.
Thank you, Mike. This is excellent. Where can people find more?
Thanks, Say. So for more information about RDoC's wellness initiatives, check out our wellness page under areas of focus on wellness, with the link being provided on your screen right now. And if you'd like to know more about the resiliency curriculum, you can subscribe to our newsletter. Just click through from the link on our resiliency page, which you can also see on the slides provided at this time.
Wonderful. I had the great privilege of having the resiliency team out for my own emergency medicine program in Saskatoon. And I have to say, they were some of the 3 most thoughtful hours of curriculum I've received actually in my residency training so far. So, Mike, moving on. I don't have any questions currently, so we'll just keep watching for those at the time. I think now is maybe a good time to step into our conversation about career intentions and national locum licensure. Mike, why is this an important issue for RDoC?
Thanks, Say. So for RDoC, it's critical that Canada has a needs-based pan-Canadian physician health resources strategy. This ensures Canada has the right physicians in the right place at the right time. The survey team worked with RDoC's practice committee to ask questions that would provide insight on residents' priorities when it comes to planning their career. Here's what we found. Residents were asked about their career intentions following residency training. Less than a fifth of residents, at 19.2%, definitely knew where to locate job opportunities in their medical specialty, while the majority, 56.7%, somewhat knew where to look. The leading reason at 50% given for selecting a place to practice medicine was proximity to family. The majority of residents at 53.4% intend to stay and practice in their current training province, which they also consider to be their home province. An additional 11.6% intend to stay in their current training province, but reported that it was not their home province. And finally, about 1/5 of residents did not know or had not decided where they would seek to practice following their training. For the 10.1% of residents who plan to return to their home province or territory following training, the top 3 provinces to return to were British Columbia at 27.2%, Ontario at 21.2%, and Alberta at 21%. Residents who intend to practice in a province or territory that is neither their training nor their home region will also seek to practice in these same 3 provinces. When asked about their intention to locum outside their future province or territory of primary practice, less than 1/5 the residents, or 19%, say that it is in their plans. Of the 82% of residents who are not sure or do not plan to locum outside their province or territory of practice, a significant proportion at 52% stated that they would locum outside if no additional license applications or fees were required.
That's quite interesting. So what solutions? Sorry,
Sorry, that was my cough.
So what solutions is RDoC advocating for when it comes to reconciling residents' desires with what Canada's healthcare system is providing?
Thanks, A. So RDoC is advocating for a national licensure, which would allow physicians to provide care across provinces and territories. This would ensure standardization, increased physician mobility, and improved response to patient care needs in various geographical regions. A robust and thorough licensure process is necessary for the protection of patients and ethical self-regulation of the profession. The high numbers of respondents who would locum outside the province or territory of practice if no additional license applications were required is a critical finding. A pan-Canadian licensure system would eliminate measures that restrict or impair labor mobility within Canada and provide physicians with an opportunity for short-term exposure to clinical care in areas of need and to patients who need care. It would provide coverage for urgent and semi-urgent practice care, encourage physicians to provide coverage in underserved areas that differ from their primary region of practice, would also increase time and resource efficiencies, and increase patient safety by having a centralized criminal record check for all provinces. RDoC's collaborative statement on Canadian portable locum licensure has received the formal endorsement of the Canadian Federation of Medical Students, the College of Family Physicians of Canada, the Royal College, the Canadian Medical Association, and the Society of Rural Physicians of Canada. Stay tuned in the coming months for further developments from Resident Doctors of Canada on this fast-paced issue.
Mike, this is so exciting. And as someone who's done electives out of province, I can see why this would be so great to improve our movement across the country. So Mike, where can people go to find out more?
Thanks, A. So you can find the collaborative statement on our website under Areas of Focus with National Licensure. We'd also love to hear from our resident members about the impact the current provincial territorial licensing system has had on them. Please feel free to send us an email at practice, Practice, at residentdoctors.ca, or at us on our social media.
Mike, you sound so hip, just at you on social media. So I have a final call to questions for anyone right now. If they've got anything they'd like to bring up, discuss, Mike and I are happy to answer anything. I'm just going to kind of give a couple seconds here, and while I'm doing that, I'm going to wrap up a little bit. I'd like to really thank you, Mike, Dr. Arget, for this amazing discussion today. I'd really like to invite all of our listeners and anyone who watches this later on the YouTube channel to visit the sites that we've listed and come on to the RDoC website. We have a copy of the National Survey Report, and it is available on our website as well. I think we're going to put that up on our slideshow. But otherwise, we're really grateful that everyone showed up and joined us for today. I'm just seeing here in the corner box that our survey themes and our survey information can be found at residentdoctors.ca /survey themes. Now, I'm not seeing any other questions. Mike, do you have any last words you'd like to share?
I just would further like to thank everyone for attending this session this afternoon and showing interest in the results of our National Resident Survey. And we look forward to chatting in the future, answering any further questions. And we are getting ready to, in the early stages of preparing our next round of the resident survey to go out in 2020.
And both Mike and I are going to be at CCME, so feel free to grab us if you have any other questions. Otherwise, we hope you really do redirect over to the RDoC website. Thank you again so much.